All right, we're on our next module called Managed Care Contracting. This truly is your governing document of participation. What we're going to look at is I want to take a look at and make sure that you have an understanding behind having or not having a contract. It's okay to say no, that you don't want a contract. I also want to have you gain an understanding of the contract structure and some of the elements that exist within a managed care contract. And of course, we're going to take a look at how you get paid and how much it's worth. So contracting, where does it fit into the puzzle? So let's go back to Module 1. We had our 4 pieces of the puzzle. We went through our credentialing and providership module. That was where credentialing sits in. And now you can see where the contracting fits in, which is if you're going to be credentialed, that's not good enough. You have to have a contract, and the contract is what's going to govern your participation. Now, do you have to have a contract to see a patient? No. When you have a contract, that's where you hear terms like in-network, you're par, you're participating. When you're not in-network, that's where you hear terms like out-of-network, non-par. So when you look at your benefit plan, you have an in-network deductible and an out-of-network deductible. That's what it means, is when you are in-network seeing people in that little box, it's the network, that is your in-network benefits in your in-network group. When you're not in the box, it's out-of-network. And what white space we'll talk about in a minute is when you're not in that box and you see one of my members, I'm going to try to get you to have some lower reimbursement. I'm a white space manager for a health plan, which means I need to reduce the obligation I have in paying you. And I want to figure out a way to do that. However, in all cases, you can see patients without a contract. Their out-of-network benefits may kick in. They may have a higher cost share. But the point is, you don't have to have a contract to see a patient. So let's chat about white space real fast. As a health plan, if you're not in my network for whatever reason it is, I'm going to do everything I possibly can to pay you less. And how am I going to do that? Well, if you remember, we talked about stacked networks, we talked about silent PPO networks, we talked about discount brokering. I'm going to try to come in and find a way that I can get your claims lower. If you remember the example I used when I worked for a health plan, we had a hospital in Alaska, and they thought they were going to get this great reimbursement, but through a discount brokering model, I was able to get that price reduced for our health plan. The hospital wasn't very pleased with me, but as a white space manager in contracting, I managed to find a way to reduce that claim so that we weren't as obligated for the full amount that it was due. It's essentially an attack on your payments from a healthcare provider's perspective. So that is what we call white space management, is when that occurs. So how about we just not even worry about that and I sign a contract? So why do I want to have a contract? Well, the only reason this whole stuff exists is because someone got in the way between the patient paying the provider, paying you as a nurse practitioner. So as this emerged, we created these networks and infrastructures and contracts, and you got to be in the network. And the whole module we're talking about is because someone other than the patient has decided they're going to be involved in the payment process. We're going to look at reasons to have a contract are going to include you're going to know what's going on. You're going to have the ability to dispute items. You're going to have guidelines. You're going to know when you're going to get paid. You're going to know the rules of how to play with that carrier so that you can get paid. What's the option for not having a contract? I can have one, but there's also an option of not having one. Not having one is kind of where a lot of people are going anymore. They're sitting down and saying, hey, I want to start being a little bit more pickier. Now, when I start a practice and we have a brand new practice I'm opening, our strategy in an outpatient model is going to be sign everything you can sign to just open every floodgate. But after a while, when I have enough patients, I need to create a financial plan to say, you know what, I don't want to see any more of you. Get rid of that contract. This contract doesn't pay so well. Get rid of that contract. We're actually in a program right now where we are terminating managed care contracts and sending patients to the wayside because I can have better paying contracts in my very busy practice. So do I want to be very busy with low paying business, or do I want to be very busy with high paying business? If I have the ability, the privilege really, to have such a busy practice, I'm going to start shifting that payer mix around, and the way I'm going to create that strategy is through my contracting initiative. So not having a contract is not necessarily a bad thing. Do I need to have a contract to be in NICU? Patient got admitted to the hospital. The authorization for that patient to be admitted to the hospital has been approved. I don't know if I need to have a contract because they're already there. They have no choice but to see me. That's where they're going to land. When a patient shows up in an emergency room, They're in the emergency room. The prudent layperson individual patient thought it was an emergency. The health plan's got us stuck that contract or no contract, I'm going to have to treat that ER and pay that ER. You can't necessarily pass that on to the patient. So in that model, no. As an emergency room, I'm not going to hold contracts with people to have them discount my services. Pay up. You have no choice but to pay me. Similar to NICU. I'm already in the hospital. Where are you going to steer patients away from me? So when we start and look at it and say, hey, look, I want to start developing an out-of-network strategy because I kind of like this idea of not having any managed care contracts. Well, to do that, what you're doing is basically black space. We'll talk about that in a few minutes, but what you're trying to determine is, can I develop a strategy to have no contracts? Well, the health plan's going to direct around me. Case management's going to say, don't go to that physician. You got to go to these physicians. Go to the physicians that are in network because financially it's going to cost you less. But a health plan cannot direct around me when I'm the only emergency room in town. That would be an option where you want to create an out-of-network strategy. Now, we do have this thing called Medicare limiting charge that you see here. And you might say, well, gosh, that is a new term. What is the Medicare limiting charge? The Medicare limiting charge says you cannot charge a Medicare beneficiary more than 15% over their allowable. So if Medicare allows $100, the most you can collect from a Medicare patient, because you can say, I don't want to be in Medicare. Many, many, many people are. But the limiting charge still comes into effect. It says, if Medicare says it's $100, I cannot charge the patient more than $115. That is your limiting charge. Only for Medicare. Well, screw it. I'm going to do my own thing my own way. Well, guess what? Read the last bullet point. No, you're really not, because penalties are now getting passed down to the providers who repeatedly and knowingly are charging beneficiaries over the limiting charge. So while the limiting charge may be $115, I'm going to charge you $150. You do that all day long, you're going to find yourself in a penalty situation. Again, only for Medicare. Everybody else, it doesn't really matter. But it's important when you look at your out-of-network strategy to know that the Medicare limiting charge is a factor. All right, let's go back to creating my strategy. Health plans have to have a network to be licensed. Now, they need you. They need you to be a dot on their map in their service area, because without a network of a comprehensive provider system, they can't sell their product. Well, that works well when you are the only neurosurgeon in town, but when there's 100 neurosurgeons in town and other options, that doesn't go so well for you. So if you are the only provider and the only thing in that rural market, and they have to basically deal with you because they have to get your dot on their map to be able to pass licensure with the state, they need you. That would be a reason you don't want a contract, or if you do get a contract, start negotiating those rates. United Healthcare said, you know what? I'm done with providers trying to control us. We are going to pay anybody who sees an out-of-network provider, we're going to pay them directly. So United Healthcare, I'm an out-of-network provider. United says, perfect. You see them. I don't care if you accept assignment or not on your claim. We're sending the check to the patient. Patient gets the check. You now have to go after the patient for the check. Well, all of a sudden in that out-of-network strategy, patient needs to pay in full at the time of service because you know they're going to get the check. In Texas, which is a provider-friendly state, Texas said, yeah, good luck, United. That's illegal in our state. So in Texas, even in an out-of-network situation where United has to pay the claim, they have to pay the provider. They cannot pay the patient. It is illegal. That is not the case, though, in California. So you've got to look at your state laws when you start looking at some of this. A little confusing. I know I'm talking really fast. I tend to. But you've got to kind of look at, there's two things. I can either have a contract or I don't have to have a contract. When I don't have a contract, I'm still going to have white space managers or health plans call me and say, hey, can I cut a deal with you to help manage this patient? The CEO's wife wants to see you as the OB-GYN. Can I do a memorandum of understanding, get an MOU, and can I just pay you to see this patient? So they're still going to come out and try to get a discount from you. It's a matter of, do you want to agree to that or not? Can you piggyback off of someone else's authorization number? If I'm a hospitalist in a hospital and the hospital admission was approved, the patient doesn't really have a say and have the ability to say, oh, by the way, sorry, you're not in network. Can you send a doctor in this hospital who is in network? Now, here's what's bad right now going on is a carrier in upstate New Jersey has decided they don't really care. It's the patient's responsibility. So if you see an out-of-network provider like an anesthesiologist or a hospitalist during your hospital admission who doesn't have a contract with that health plan, they're applying it to your out-of-network deductible, and you have to basically fight it. Now, that is really bad, but it's happening. So they don't really care about the situation or the place of service anymore. So that last part, I'm piggybacking off someone else's authorization number, is starting to become a lot weaker because the health plans are fed up with it. So, black space management. White space management is the health plans trying to negotiate and discount your services any way they can when you don't have a contract. White space managers also, how will they help get a lower rate for you? They're going to contract you to be in the network. Black space management, this is all about you. This is about what are you going to do to make sure you don't get white space managed. You're going to have the requirement that all your networks need to be identified in your contract. Well, when you start reading the contract and the assignment, you're going to see a term called affiliates. I want you to pay very close attention when you read that clause because it basically says, hey, anybody that I own 50% more in a network or situation or related to me and all these things are going to have access to this discount. So those affiliates become quite an important term to use that we'll see about. I'm going to, in my practice, route any high dollar negotiation to the most skilled individual in my practice. Am I going to let potentially the front desk person answer the phone from MultiPlan and say, hey, we have a contract here. We'd like to, on this one patient, to offer you XYZ for reimbursement. Will you accept it and can I send you a letter over to sign? Absolutely not. You're going to get that to the person in charge of your business office and say, you negotiate this because that individual is going to have the skill set to be able to negotiate and deal with that. You're going to see claims that come out and say, hey, by the way, you charge $900 for this service. That is not usual and customary, and we're going to adjust that down to $400 because $900 is not customary. So we're going to start at $400, and that's what your new usual and customary rate's going to be. Who on earth allowed that health plan to have the determination to determine what my usual and customary charge is going to be? Market has, but we're going to talk about this a lot more when we go into our next module, which is charge setting. But when I set a charge, and when you set a charge, as you're going to learn in the module, you're going to have a very systematic way to define and say, no way are you going to use that allegation as a way to discount my service because I can jump up and down on the table and defend that my charge is usual and customary and that you, health plan, are just trying to find a way to discount me. These are arguments your business office should be having, not just rolling over and accepting that, okay, well, that's what they said. Not acceptable. Practice should have out-of-network metrics. How much is what you allow that discount to be? You might just say, nope, not going to do it. What levels? What's your reimbursement thresholds? You've got to set this up if you're going to have an out-of-network strategy or black space management. And obviously, we digitized both sides of the patient's ID card. So why do you think we did that? Do you think it's because we wanted to say, hey, we want to make sure we get that claim to the primary payer and get it to the right place? No. It's because when that claim comes back and I'm expecting to be paid $1.25, and instead I'm paid 75 cents, you better believe it, I'm going to pull that ID card out and look for every silent network. I'm going to look for the discount broker, and I'm going to look for logos that were possibly missed because I'm ready to go to battle to get my $1.25 versus my 75 cents because that ID card did not have that company's network logo on it. It was not disclosed ahead of time. Don't silent PPO me. And that's where you start your argument in battle. If you don't have skilled people in your business office doing these functions, you're missing out on all these strategies, whether I have a contract or don't have a contract. This is what accounts receivable recovery is about. This is what your accounts receivable team should be doing. It's not just working the claims, it's using the strategies of in-network and out-of-network to generate the most revenue you can for your practice. So, do I want to have a contract or be a network or not? It's white space versus black space. Really, the white should be called red because they're trying to discount you and I'm going to lose money, but it's white space and black space management, which is actually the industry terms. That is the first section, and I want to look at That is our first section. So I'm going to stop there, and then we'll get our next video.